So EGFR-activated mutations are detected in about 10% of patients with Caucasian ethnicity having a non-small cell lung cancer adenocarcinoma. In the East Asian population, the incidence is much higher and is around 35 to 40%. Detection of EGFR-activated mutation is very important when planning treatment for advanced non-small cell lung cancer patients, as these patients will be treated with an EGFR TKI, which has been demonstrated to be better in terms of response rate, progression-free survival, and quality of life compared to standard chemotherapy. So there's been a lot of data in the EGFR space presented at ESMO 2018. And if I could select only 3 of these studies, certainly I would like to discuss the data from Dr. Ramalingam and colleagues who presented the resistance mechanism from osimertinib in the first-line FLAURA study. And the authors described the mechanism of resistance from paired plasma samples. So they had 91 patients who had plasma samples that showed the EGFR sensitizing mutation. They were also retested using a ctDNA at progression. And looking at the mechanism of resistance, the most incident one is the MET expression, about 15%, followed by the presence of a C797S mutation, about 7%. Less common mechanisms, but equally important, are the presence of a BRAF mutation, the presence of HER2 amplification, but also PIK3A kinase molecular aberrations. The fact that these analysis was performed in plasma samples only, unfortunately, doesn't give us any information about the incidence of small cell transformation, and certainly when the data will be presented on tissue, we may have a different incidence of MET amplification, for example, which is likely to be higher compared to plasma. Why this data is very important is because it gives us further insight in the biology of the tumor at progression from a third-generation EGFR TKI, and that will be helpful to understand how to manage these patients and to put this data into context when we need to decide what's the appropriate sequencing for these patients. Another very interesting study, which was a late breaker, is the phase 2 study by Dr. Tan and colleagues, who reported on a phase 2 study evaluating single-agent nazartinib, which is a third-generation EGFR TKI, as a single-arm study. The authors evaluated 45 patients, which were enrolled in 12 centers, and nazartinib demonstrated a response rate in the region of 63%. This is a third-generation EGFR TKI with good penetration in the brain, and in fact, when they presented the data on the patient cohort with brain metastases, they could see a response rate intracranially around 50%. In terms of toxicity, what stands out is certainly the high incidence of severe rash, which was about 9%, and this is much higher than what is being reported in the previous EGFR TKI studies, and certainly much higher than the direct competitor, which is osimertinib, which is another third-generation EGFR TKI. So certainly this agent is active, it's got a very good penetration in the brain, but the question is, do we need another third-generation EGFR TKI? Perhaps we don't need another single agent, but it will be important to see this drug together with other companions in terms of anti-MET or other mechanism of resistance to see what happens at progression from, let's say, third-generation EGFR TKIs. Another very important study is a study by Dr. Cambridge and colleagues, which is a phase 1 study evaluating an antibody-drug conjugate called teliso-V, either as monotherapy or in combination with erlotinib in a cohort of heavily pretreated advanced non-small cell lung cancer patients. This was a phase 1b study. It was an initial part with a dose escalation looking at 2-weekly and 3-weekly schedule, and where the patients were not selected for any biomarkers. And in the expansion cohorts, all these patients were selected by c-MET expression using immunohistochemistry with a central lab analysis using an H-score of at least 150. The authors presented efficacy and safety data in the monotherapy cohort and also in the teliso plus erlotinib cohort, which were c-MET positive, but also EGFR-mutant non-small cell lung cancer. What is important to point out is that the median number of prior lines of therapies for both cohorts was about 3, and in the cohort of teliso-V plus erlotinib, about 58% of patients were already treated with a third-generation EGFR TKI. This is very important to bear in mind when looking at the data. There was interesting activity in the monotherapy squamous cohort with a progression-free survival of 6 months. Looking at the teliso-V plus erlotinib, the response rate was 30%, and the progression-free survival was more than 6 months, which is very impressive if you consider that this was a heavily pretreated population. More than a half already had a third-generation EGFR TKI. So we know that c-Met is becoming increasingly important as mechanism of resistance from first or second generation, but also third generation EGFR TKI, and certainly the data on teliso-V plus erlotinib warrants further exploration in this subset of c-Met positive EGFR-mutant non-small cell lung cancer patients. I think the next questions to be addressed are how to tackle mechanism of resistance after a first and second generation EGFR TKI, or very importantly after a third generation EGFR TKI. We now have a deeper understanding of the tumor biology at progression, and a number of studies are ongoing with different agents trying to tackle the different mechanism of resistance, and these studies are likely to read out over the next 2 to 3 years.